sending questions your way, let's talk about what it's kind of been like moving from school to.
Yeah, so right now I'm practicing in La Quinta. So it's about, a couple hours from where I grew up, but reason why I'm here is because of my girlfriend. So um did not expect myself to end up in the desert, but here I am, and it's so far it's been great. So I actually started in April, worked a little
Mhm,
bit as a CA before I
mhm.
got my license mid-April.
Oh,
And
okay.
then basically in patient demographic, it's been really interesting and a good learning curve because in school I felt like I didn't get a good grasp on geriatrics.
Hmm.
Um, Even though that Dr. Nook did teach us geriatrics and same with Dr. Souza for the lecture part,
Hmm.
I was not very, I guess I didn't just grasp it how it would turn into like practice,
Yeah,
especially on the
totally.
clinical side.
Hmm.
So, so far it's been a little bit of a learning curve, but my, excuse me, the doctor I work for actually has helped me a lot. He's been here since like 2007, so he's known the area pretty well.
Awesome.
And I would say maybe 85% of my population is geriatrics. The other
Oh,
15% has to be maybe like people below 40s. Yeah, so once I got done with being a CA, just kind of learning the ropes of like the therapies. So we have like shockwave, laser, decompression, and then PMF. So we kind of just do that and then do some adjustments. We have some flexion distraction, some arthrostim. Um, Me personally, I don't adjust everybody. Adjustment's more like of a tool for me. Um, but I guess to go back to your question, so I think it's been pretty good. I would say similar to you, it's time management, going from school, adjusting maybe like two or three patients like every other day.
mm,
That was a lot slower than what I'm used to now, where it's like I think I'm seeing 80 to 100 per week, and I only work 4 days, so it's been a little bit hectic. Um, at first, it was definitely just trying to stay on top with like, okay, speed and not falling behind schedule.
yeah, yeah. It's a crazy how different kind of things can be, and we kind of talked earlier about trying to remember everything that we had going on in school, and it felt like we were just so on top of it, and then you get so into just rolling through patients every day and
Right.
switching between different conditions and different conversations and stuff. It can be definitely a challenge to kind of pull all that back in and use it efficiently for sure. So you guys see mostly geriatrics. What sort of like
Mhm.
conditions do you find that you treat most?
The ones that I treat most are spinal stenosis for sure. Um, Lately, I've been seeing a lot of disc herniation people, and so it's mostly obviously low back and neck pain.
Hmm.
Um, with the neck, a lot of arthritis.
Hmm.
So I would say, yeah, arthritis, spinal stenosis, and disc problems.
Okay. And then you
Yeah.
said your adjustments are kind of a lot more, not your regular treatment style. So what sort of thing was your kind of not necessarily a go-to, but pretty consistent tool for you to use?
In school, it was more obviously diversified. I felt more comfortable with kind of learning everything and then just applying it to the patient's conditions. In practice now, it's a lot different because I think I'm used to my adjustment flow being very quick. So like kind of similar to you, I know we talked about how you see about 15-minute treatment sessions.
Hmm.
I do the same thing, but we have it in blocks sometimes. Like people could schedule two or three per 15 minutes, so it's like I'm bouncing around a little bit. Yeah, so I'm still doing diversified, not much Gonstead. I've incorporated a bit of the Y strap actually,
Yeah,
and it's been
absolutely.
helping a lot with a lot of decompression for the older population here. So I've been
Hmm.
getting really good results on that.
That's
Yeah, so
awesome.
I guess in short, nothing really has changed. I've been doing a lot of prone cervical moves. I would say that.
Okay. Okay.
Yeah, yeah. Prone cervical moves.
And what leads you to
Um,
go like for the prone? Because I know sometimes it can be just a different adjustment for some people.
yeah, yeah. So technically we have people come in, they go lie face down.
Yeah.
So for me, it's easier to just do everything face down, but it also depends how the patient presents. So, like, if they can't lie face down, then I'm not going to have them lie face down.
Yeah.
If they go, if it's better face up, or if it's seated, then we'll do either or.
Yeah.
Yeah,
And so nice having different tools to be able to keep modifying the adjustment and be like, we could still make this happen.
right.
Just work with me and we'll put you in that position that's comfortable for you. And then boom, here you go. And are you doing like a lot more because of kind of that older population? Are you doing a lot more like drop adjustments than you would think before? Or
Oh, anybody probably like up until maybe like 45, 50, I'll still do a side posture,
yeah,
but it's nice to have the drop and the arthro stim to kind of save my hands
yeah,
and the
yeah.
biomechanics too.
Arthrosim's not one I'm super familiar with. Can you explain a little bit more about how that works for you guys?
Stim basically is kind of like I would say a more percussive activator in a way. So it just
Okay.
acts as like a light adjustment tool, not applying a lot of force as if you were doing manual.
hmm
And it actually just feels good for patients.
And so with you did your preceptorship in that office?
I did not. So my
Okay.
preceptorship was in Palm Springs, which is 30 minutes away from where my office is now. Actually more traditional chiropractic style versus the one in La Quinta where I'm at right now is more up to date with the technology and evidence base. So my experience with my preceptor was good for the most part. I think it was, we did only a couple therapies, so like hot packs and then Easton,
hmm
and then that was it. And then pretty much relied on adjustments.
And is there is that kind of one of the biggest things that you'd say you like learned from your preceptorship is kind of being able to take a step back and think there's got to be a better way to do this?
Yeah, yeah. So I actually found myself digging more into Seuss's book,
Yeah,
the differential diagnosis, and that helped me a lot.
yeah,
And then ultimately, that's where I was like, you know what? I think I kind of want a really good adjuster, but also clinically sound and making good judgment and calls on that.
yeah,
Um,
absolutely.
I think personally, I just want to be a better provider going forward. And that's not to say that like my preceptorship was a complete flaw, but um, I just felt like I could learn more and
Mhm,
provide better service than what
mhm.
I was accustomed to during preceptorship.
And then, so how many patients do you use your practice like if you're not up to full speed, but like what would be your full day? Like, are you pretty high volume or how's that go for you?
So here in the desert, we go by seasons. So
Mhm,
summers, since it's really hot, a lot of the snowbirds, like the people that visit and have places here in the desert, they leave by at least like end of May, beginning of June. They return in the winter. So like summer is very low, I would say. On average, I see still maybe 18, 20. Um, so then, yeah, and then winter I heard is like where it's like almost 45, 50 a day.
mhm.
So it's definitely a different ball game probably when it comes to winter. So I
Yeah,
just trying to get my speed up in regards to that, but also provide good patient care on top of it, like building trust, rapport, all that.
yeah, awesome. So with all that, what's your new patient sort of protocol or not protocol, but what's a usual new patient visit for you guys?
Yeah, so whether they call or walk in, they fill out an intake form, kind of tell us what's going on. Then we take them back, take some vitals. Then, yeah, take some vitals. Then we bring them back to our x-ray room, and that's where we kind of do our new patient exams and history taking. So usually the history I do is probably a little bit under 5 minutes because what they already came in for is already on the intake. So kind of just building effective communication through that like 5 minutes and then just kind of figuring out from them if there's anything else that they didn't mention. Um, so do that and then we do like a brief exam, just a few orthopedic tests. Be about 8 to 10 minutes. Then we bring them back to the front so they can schedule up their follow up and then we bring them back into a room to get started.
Okay. So you guys schedule a follow-up and then but still treat the same day?
Correct.
Okay, gotcha.
Yeah.
Okay, nice. And do you usually, even though you go back to the X-ray room, do you X-ray still?
It depends. So it depends if it's a kind of a reasonable, depending on their condition. Like I said, like on their age, or um, if we're trying to rule in or rule out anything else that's not given in the history or the
Mm-hmm.
exam, then we'll take an X-ray.
Mm-hmm.
But yeah, I would say like not all the time.
Super amazing tool to have, but I think in some practices it gets overutilized and a little bit too much importance put on it in a way, you know.
Right.
Yeah. Um, and so being chiropractors, kind of one of the favorite things that I always look forward to with choosing this career was kind of the work life balance and making sure that, you still got to have your free time and go out and have your fun and stuff. And so how have you been finding that?
Honestly, so when I first started as a CA and then a little bit into getting my license, I had a really good schedule. I still do. I only work 4 days, so I have Fridays off. Um, Tuesday mornings before I didn't have Tuesday mornings, so I went in at like 1 and I
Hmm.
was off at like 4:30.
Nice.
So it was pretty good. Um, but now I would say it's still good. It's just now I'm studying for my X-ray license, so I'm trying to do work and then also get it
Hmm.
back into the habit of studying. So it's a little
Yeah.
bit hectic. And then yeah, so like I live with my girlfriend, and so sometimes when she's not in the hospital, since she's a nurse, we try to do stuff. I recently picked up pickleball. Just
Nice.
try to build affinity with the community out here, and
Yeah.
I met some really cool providers and just people in general. And so I would say, yeah, it's a pretty good work-life balance
Yeah,
when
that
it's
sounds
not
awesome.
hot.
Yeah. That's the only question I really think that I kind of want to ask right now is like what sort of things do you feel like you've learned since you've gotten out of school, since you've gotten, away from the preceptorship, maybe something you learned from preceptorship, but things that just kind of how your treatment style has evolved now that you're kind of out in the real world, so to speak, and you kind of have different mentors than, everybody at Palmer was kind of, built around kind of shipping the same sort of curriculum to us and stuff. And now it's kind of like, other providers are like, hey, do you think about this? Do you do it this way?
I would say the same values I've kept throughout school and then going into preceptorship and then now is still there. So like kind of just doing everything with like integrity and respect. And I think that goes a long way too, especially doing patient care. I
Hmm.
think especially from my experience, patients kind of want to see one to respect the professionalism and the trust since you're building rapport and working with them. They're coming to, they're basically paying to see you to get
Hmm.
them pain free. So I would say trust has been a huge one.
Hmm.
Communication for sure. Like patients want to know if you're gonna get them right, if you are their quote unquote savior to get them pain free.
Yeah.
They're not going to spend their money on you if you're not the man for the job or the woman for the job.
Hmm.
So communication is definitely crucial, and that goes along with like marketing. So I think marketing has been one of the stepping stones too, because not only are you a healthcare provider in the medical and healthcare field, but you're
Hmm.
also in a business. So it's like you also have to realize, okay, how do you combine the two to run an efficient office and
Hmm.
also just do good clinical work? So
Yeah.
I would say those three things, the three pillars, trust, communication, and marketing, probably the big things.
Yeah. Yeah,
Hmm.
absolutely. I almost wonder if it's one of those things that you just can't really get in too much until you just start getting kind of the reps in and just,
Yeah,
just trying different things and seeing what's working. And um, I agree that within school, it seemed like they talked to us about things that should be communicated, but not necessarily how to communicate those things.
right.
And they talked a lot about things that we should say, but not necessarily things that patients will say back to us and how to respond. And so that was always one thing that anymore I kind of get into a point where I'm like, okay, now this is my time to figure
Yeah,
out what to say next.
yeah. No, definitely. And I like how you kind of went on the repetitions. I think back in what preceptorship, I adjusted, but like didn't get to like as when
Mhm.
we were in school.
Yeah.
So like once I got out into La Quinta into the practice I'm at right now, I think reps have has helped me a lot, especially with taking history, with time management, adjusting skills too. I've definitely seen an improvement. I'm not like a god or a pro at adjusting, I would say, but I would say that it's gotten a lot better since being
Yeah.
in school and preceptorship.
Yeah. Every time he adjusted meat back in the day, it was always good. So you
But
can
too
only go
much.
up. So it's always, I'm sure you're pretty much an ace anymore. Yeah, it's definitely been one of my favorite things about getting into practice is having the ability to, get reps in and, miss sometimes and, either figure out what to do after, that adjustment didn't work or that treatment's not really making as much improvement as we can. And, trying different things. And especially for us in our practice, it's just always a evolving sort of game. And we figure out, oh, that we tried that and you were open to trying things, but we're not going back there because that was awful and it didn't work for you. So
Right. How
nice.
about you? Any new ones?
Oh, yeah, yeah, a few good new ones. The first one that comes to mind for me is the way that the patient does the like leg lift test. They're
Mm-hmm.
prone, and you see which one goes higher. And we were kind of taught that the low leg is like a PI side,
Right.
but the doc that I work with kind of, I don't know if he was just taught differently or, in my perspective, it's kind of extrapolation of that. You kind of think about the pelvic torsion model. And actually, instead
Mm-hmm.
of thinking about that's the PI side, we look at how the sacrum's rotated. And that could be like either apex left, apex right. And then he just does like a drop blast on that thing, just kind of set it back. So you don't have to do a side posture sacral apex move. And I found it to be like pretty effective. It's
Oh,
pretty cool. So that was
I
kind of
feel.
we don't have a Y strap, but we actually call it the towel because we just use a towel. But it's that
Oh, that
same
one.
sort of
Okay.
just Y axis decompression adjustment.
Yeah.
I would do that occiput lift back in school, the prone sort of thing we were just talking about. But now it's just like I've actually done that like a fair amount of times, and I don't use it all the time. But like those patients where things are just moving well, or maybe not moving well, but they're still just kind of lingering in there, and it's just like and people are just like, whoa, that was awesome. I'm
Yeah.
coming back next week for that. I'm like, all right, sweet. Yeah, that's been one that I've given a lot more shots and that's been working out really good. And some of my favorite adjustments are adjusting people's feet,
Hmm.
doing
Yeah.
like getting in there and really just not only just the talus, but like navicular, cuboid, cuneiforms, get the toes. Calcaneus is, everton. And like when people stand up again, they're like, okay, all right, and it's amazing too to see how many people you adjust their extremities or whatever, and they get up and they feel awesome, and they're like, I've never had a chiropractor adjust my extremities. I didn't even know you could do that. And it's like, yes, yeah, we can. Welcome to
Yeah.
the good stuff. Keep coming back,
Right.
y'all. Yeah.
Yeah. That's cool.
Oh, collarbone. That was another thing that my doc
Hmm.
has kind of showed me that not really like Dr. Nook kind of taught us how to like, assess an external rotation, internal
Right.
rotation, abduction, thinking it's all these things. And he's kind of like, what he does is just puts his thenar just right on top of that clavicular head. And then you just kind of grab it with your other hand, kind of reaching around the patient. And you just kind of pull on a big breath out and then just shove it to the side. And it's awesome how much that helps the shoulder out like quite a bit.
Wow. Wow. I've never heard of that one. That's actually a new one.
Yeah, that one's it's surprisingly effective. I mean, when you're going through the shoulder and you're adjusting humerus, AC, you got all that rolling, and it's like,
Right.
let's give that clavicular or clavicle a check, and it does a pretty good amount of time.
Okay. Well, that's
All
going to go in
right.
the video for sure. It's kind of like your initial exam when new patients come in and then the follow-up visits for that.
Yeah. So our new patient exam is set for about 45 minutes. If we need to take longer, we definitely do. But patient comes in, fills out some pretty simplified paperwork, just kind of really specific about what's been kind of bugging them the most, how much that's been interfering with everything they've got going on, and kind of like a little review of systems on that paperwork and some family history stuff. Then following that, we go ahead and just put them back into a treatment room. And then doc will come in and talk with them about what they have going on. And for the most part, we keep our history a lot like, you had explained, just pretty effective, efficient use of time. So maybe last 5, 10 minutes, something like that, depending on how complex the issue is. We'll kind of dig into things, but we'll jump into orthopedic testing after that with some range of motion as well. It's been pretty cool getting into practice and using just kind of really specific orthopedic tests along with the range of motion really I've found tells a lot, that sometimes the range of motion is pretty much all you need unless you're looking for like red flags or really trying to find something specific or you're chasing some neurological symptom. People with mechanical neck and back pain, it's like, does it hurt with stretching or does it hurt with compression? And then you can kind of go into there of like, is this a sprained muscle or strained muscle, sprained ligament, or is it something intra-articular that needs to be released with like a good adjustment? So following all of that, we'll kind of pick them up really quick, talk to them about what's going on, saying, these are the things I found through the exam. I think this is your diagnosis at this point. We're going to do this and this and this for you. But in our office, especially because we take so much insurance, we're really just based around the adjustment. So treatment at its foundation is going to include some adjustments. And so then we'll just talk about, whether they're up for the manual adjustment, and most people are, and that's usually where we'll start anyways. And then we'll just get them back on the table and we just kind of walk through each adjustment as that for that first visit, just making sure everything's nice and comfortable for them, and that we're kind of building that rapport and trust that we're not just going to throw things at them that they don't really expect, and that everybody's on board for each little step of the process and stuff, and then see how everything's doing. If they're in some good relief, then we'll call it kind of good for that day and then schedule their follow-up. If not, then we'll kind of keep looking at what else we can do. Mostly that's just includes either like some sort of different style of adjustment for that spot, or if it's like a low back thing and it's still kind of hanging on there, we'll probably do some flexion distraction, something like that. After that, we kind of talk about what their treatment plan is going to be. I like to see people back at least just one time, just to make sure everything's been good since the first adjustment, that the soreness that you kind of would expect from being adjusted your first time is something that was mild to moderate and has gone down in the since the like couple days after your first adjustment. So we know everything's kind of going well. And appointment basis, like if they're responding well, then it's like awesome. Maybe 2 or 3 appointments within a couple of weeks is kind of usually what we would stand around. If they're not responding super well, we'll kind of start looking at doing some more like soft tissue things, seeing what else we can do if we need to refer, but we'll kind of stretch out the treatment time a little bit that way. The older people that have kind of long-standing chronic issues, it's kind of one of those things where you got to kind of let them know like this might not be a one and done thing, that we're going to really work on this hard in the next like 3 weeks, and we should be at a pretty good point then.
Now I understand that you're in Spring Creek, Nevada, a rural part of the state. Um, and I know you see a lot of like blue collar workers.
Mm-hmm.
What has been your experience like with them, and what is one thing you've kind of learned within the community to basically get patients more aware of what chiropractic is?
So for us, it's a lot of mining, a lot of rancher people. Yeah, like you say, very sort of tough people that come in and talking about how they have like a really high pain tolerance and they're dealing with all these big loads and big efforts that they have to have all day. For us, it's a lot of that, just kind of explaining that chiropractic is going to be those things that keeps them going through all of that they have going on. Especially with miners, it's never easy on them. Miners will get on a bus and be driven out to their mine site, which is usually like at least an hour, 2 hour commute. And so then they're all packed in on these buses and stuff. And so it's a lot of like communication about what they can do during work, what they can do on the bus that's going to keep them from, feeling super wrapped up in pain. But for the most part, we just kind of work with them and let them know that working for you, and there's nothing wrong with coming in every few weeks and continuing on to like that sort of wellness maintenance care that we talk about. just making sure that you stay feeling good, that you stay able to do your job, that you're able to get back home to the kids at whatever hour it is and enjoy some time with them. And you're not just, fighting stress and pain just every day because your job is hard. Like it's understandably hard. And, we're here to just take some rocks out of your bucket.
What has been like mostly your experience like out in Spring Creek?
Oh, the experience has been certainly a different one. A big exchange from, working on patients in California and stuff, especially in a really adjustment focused practice where we're really low tech. We have, flexion distraction and drop tables and an activator, hot packs, but we don't have e-stim, ultrasound, really any therapies. And so the biggest thing for me is really learning how far I can take things with just manual therapy and my like cups and tools and things that I have that even though sometimes I look at a condition and I think, man, that if I had all these things, it would be awesome. But there's still like things we can do, and a lot of that sort of active care things that you can provide to the patient to be able to be like, I'm going to do this here. We're going to loosen this up. We're going to help with the blood flow to this, but I need you to be at home working on this too, because otherwise this is just not going to get that far. And so I think that's been kind of one of the biggest things for me is figuring out what I can do as much as I can do for the patient with kind of very little tools at my disposal.
I preach the same thing. Like we do some corrective exercise after the entire treatment session
Hmm.
for especially the new patients. And then the follow-up visits, like if they have subsequent ones for their treatment plan, we'll kind of ask them like, hey, how's the exercise going? Like, have you been on top of it? Because obviously we're not going to be with them 24/7, so we want them to do something at home to prevent
Yeah,
them from coming back in. That's the whole
yeah.
point. Um,
Mhm.
so do you guys do a lot of corrective exercise too? Is that what you're kind of giving your patients?
I do for sure. It's not like the biggest theme in the office is to do it for everybody. Dr. Malden's definitely very big on insurance really only pays us well for the adjustment. And
Right.
the whole office, he's been in Spring Creek since 2015, and he's kind of really steeped in himself in solely adjusting. For me, active care is very important, and I'll usually give the patient at least some sort of exercise, at least one exercise from the very beginning. There's something that everybody can do, and maybe you don't have the ability to do some sort of big thing, but a lot of those things like shoulder pain, a Codman pendulum, oh man, it seems like it does nothing. But if you're in an immense amount of shoulder pain, you could just get that thing just moving around a little bit. That's got to be better than nothing. And and you just kind of teach them about how you're not going to go to this point where you're like, no pain, no gain, rah, through my
Yeah.
therapeutic exercise. It's like, no, you gotta know your limits, and this is supposed to help you, but you're not going to do so much that it's just going to kind of hinder you in the long run or in the short run. Either way, you don't want to, yeah, you don't want to do too much too fast. And it's like, it is
Right.
one of those things where it's like, yeah, I'm going to give you this. And if it is too much for you, sure, throw it out the window, but let's talk about it next time and let's figure out something that does work for you. Because my biggest goal with all of this is to give the patient tools that they have so that they can go home, use those things in between treatments, continue to feel better. We start progressing and stretching out treatment, you know, appointment times, 1 week, 2 week, 3 weeks kind of things. And then pretty soon, I'm seeing them every 2 months for some wellness care. And they're like, I'm doing all these exercises. It's been awesome. And then they're kind of like, I actually had this big flare up of back pain the other day. And I did these couple things that you taught me, all good to go. I'm like, heck yeah, that's the job. Like, I'll take you when you're super severe and you know that something's locked in there that needs to be moved. But for the most part, if you can get in there and just do a couple little movements that's going to help you out, then yeah, there's no need to come into me. Do your thing, man.
Yeah, patient education and then just the little details go a long way.
Hmm.
Um, that's like I do that with my patients too, exercises and then honestly just the Y strap too, like decompression, I'm sure like even if it doesn't cavitate on um with that, like with that patient, like even a little bit like does a lot for them. So yeah, one final question. If you were to give a piece of advice to current students or soon to be graduates or just recent graduates, what would it be?
Oh, it's a tough one because I feel like there's so many little things that once looking back, it's like, oh, I could have done that just a hair more, explored that a little bit more. All in all, we talk a lot about communication and we talk a lot about um, you know being thorough with your exam and being thorough with your treatment. I think the biggest thing is where it really starts with is kind of that history and knowing what you're going to do with exam. Patients will come in to you with some signs and symptoms that don't seem like they correlate at all, and they might have a preconceived notion about what they have going on in their body, and it's not our job to necessarily tell them that they're wrong, but it is our job to kind of explore those things and not necessarily validate that what they have going on is that that's what's going on, but saying that, I understand that you feel this way and you feel that this is going on. Let's check it out. Let's see what's going on in there, and if I find something, then we found something. If we didn't and we found something else, then it's like, hey, like objectively, we have these things. And I think this is what's going on, even though you felt like it was this when you first came in. Now we're in this path where you and I are both on the same understanding that this something is a lot more simple than we thought. And, this is what we're going to do for it. And it's going to be awesome.
All right, Tucker. Well, thank you for doing
Of
this. And I know